Hey everybody, welcome to conference. We're doing a dual conference again today, so we have some people in person here at the VA and then the rest of you joining via Zoom. So thanks for joining. We'll have some whole EV questions today, and so please log on if you're able to answer these. Today's conference is another IM Basics conference, but I had huge help putting this together by Dr. Graham Block, who's also joined us via Zoom. Perfect. And he is essentially going to be one of our experts today and walk us through the case and help understand the answers to the questions that I'll be asking. So thank you, Graham, for joining. Cool. So today our objectives are to define and identify opioid use disorder, understand how to treat OUD patients, and then remembering that harm reduction techniques exist and then promoting them for our patients. I think too often we put these patients in a box and they get mistreated or undertreated because of their opioid use disorder, and how it's important to treat that disorder, but as well to treat their other medical conditions to the best of our abilities. Cool. So before we get started, just a separate internal medicine primer. So we do these exercises in each of my conferences, and we're done with our echo series. So today I have a chest x-ray. And for those of you who are logged on to Poll EV via your computers, can place a marker on where you think the abnormality is. And then you guys over at the VA, whenever you see the abnormality, feel free to shout it out to me. The image is not as clear as I was hoping, so you may not catch this one, but that's okay. Steve said something to do with the diaphragm, but the abnormality is not near the diaphragm. Okay, I see Chris, who is our third-year resident, also squinting, so I'll just give this answer away because I'm sorry, the image is not as clear as I wanted it to be. Just remember when you guys are reading chest x-rays to look really clearly at the periphery. And so in my chest x-ray reads, I usually go from outside in, and in this patient, if you look carefully enough, on the left apex, in the previous image, you can see there is a line. There's a small lucency here. And had the image been clearer, you could more easily pick that out, but just remember to look all the way up to the apices to make sure that patient has vasculature running all the way to the periphery. And on this side, they don't, and so this person has a left apical pneumothorax. Cool. Okay, so for our case, let's get started. So you're seeing a 54-year-old man who's a lawyer in your clinic. He has been taking oxycodone and wants to talk to you about this. And the reason is that he started taking this medicine after a dental procedure, but is now buying these medicines or opioids on the street. And he's seeking care because he doesn't want to lose his license. And so having given you just that much information, what other questions do you need to ask this patient?
How much, how often, other drug use, heroin or other things to kind of.
Yeah, great. So Ben asks, how much is he using? How often is he using these opioids? Does he have a concurrent other substance use? So is he using any heroin or other substances? Yeah, is he having withdrawal symptoms when he tries to stop? His use sounds risky. Okay.
Common alcohol use, and if there's anybody who's with him who's using those.
Yeah, great, Steve. So Steve again asked about concomitant alcohol use, and whether he has people around him when he's using these opiates. And why do you ask that, Steve?
If anybody can observe him going down.
Yeah, just so that if he is using opioids and there's a risk of overdose, that there maybe are people around that can get care for him. Yeah, Rosa?
He also doesn't really like anybody else. So
Yeah, so maybe take a wider scope and do the rest of his history to see what other cares we can provide for him. And then, has this patient developed tolerance, consequences of use? Great question. Yeah, awesome. So Ben asked, like, why is he here, and what kind of help does he want? Does he want to stop? Does he want a medicine to help treat this? What's he looking for today? Great.
If he wants to stop what he's already tried.
If he wants to stop, what has he tried before? Okay, good. Yeah, these are great. You guys can keep chatting them or shouting them out if you think of more. But here's the information you get, is that he's missed 2 trial dates from oversleeping, and that he has tried to stop, but the cravings are really strong, and then he gets ill when he decreases his use. So based on all of that information, what do you guys think is the diagnosis? C, okay, opioid use disorder. Okay. Does anybody disagree with that here? Do you guys think he has opioid dependence? Yeah, everyone's nodding their heads, but they think the diagnosis is opioid use disorder. Awesome. So now we're gonna have Dr. Block go through what the differences are between these terms and how we define opioid use disorder.
Yeah, thanks, Sneha. Thanks for letting me jump on here. So just want to start by saying, we're paying a lot of attention to the COVID epidemic, rightfully so. After going down last year, opioid-related deaths went up again, are now at their highest level that have ever been, mostly driven by an increase in fentanyl use. And current opioid overdose deaths are now worse than AIDS was at any point in its trajectory, worse than gun accidents or car accidents. So just because we're focusing on other stuff doesn't mean the opioid epidemic has gone away. And I think speaking towards this question, I think you guys asked really good questions, which is what's the difference between opioid use or opioid tolerance and what a use disorder is. So, Sneha can go out and do meth on a weekend and she doesn't have a meth use disorder because she's not using it in risky situations and she's got her habit under control. So I think it's really important to sort of differentiate that, ask sort of life questions and figure out what's going on and what problems the substance is having or posing on their life. And I think, the really trickiest way or patient that presents with this is the patient who's on chronic opioids for pain, like this guy was originally prescribed for. It's pretty clear from the history here that he's having damage to his job, he's withdrawing, he probably has tolerance, and he's got physical problems as well now. So I think he now falls under an opioid use disorder. And when you're thinking about medication-assisted treatment, you're thinking about people with moderate to severe opioid use disorder as sort of characterized by the latest DSM.
Thank you, Graham. Awesome. So just to expand a little bit upon what Graham already said is that these ideas are a bit outdated, the ones I've outlined here, but you can think about it in this way, which is that dependence is really a physical characteristic. And so imagine somebody who may have sickle cell disorder and they're on chronic opioids, and they may be dependent on it because if they don't take them, their pain rebounds, their body needs those to feel and function their best. But they don't necessarily meet a DSM criteria for opioid use disorder. The use disorder is truly a mental and physical, quote unquote, addiction. And then remembering that this is a mental health disorder. And so similarly to how we would treat diabetes, fracture, bipolar disorder, this is a disease that needs treatment. And so moving on then, so our patient is now characterized as having an opioid use disorder. So that's what he's being evaluated for. As Steve asked, he is interested in starting treatment. And so what do you guys think is the best management for his opioid use disorder? Okay, I'm hearing C, buprenorphine naloxone. Steve, tell me why you thought it was C rather than any of the other ones.
I think like both C and D are good options. I feel like both Suboxone and personally, I've seen more people off Suboxone here, but I'm just using kind of a fallacy there of like what I see more often, not necessarily maybe it's that time.
Yeah. Do you know what one patient characteristic I gave you that may make him a better Suboxone patient than methadone? Yeah, he's a lawyer. And so sometimes, we know that highly functioning people can have use disorders, but that he may not be somebody that can make it to a methadone clinic every day because of his demanding job or because of any job that a person has. And so take those social factors into account when you're thinking about which medication would be best for them. So yeah, so I also thought that buprenorphine naloxone would be a good treatment for him. Just to remind you guys, naloxone alone is not good because that will precipitate withdrawal and doesn't actually treat the use disorder. Naltrexone has been used, is third line after the other two B and C options, but remember naltrexone can also precipitate withdrawal as it's an antagonist, and so the patient has to be off all opiates for like 2 weeks before you can even think about giving them a dose of that. And then clonidine we do sometimes use, that's an alpha antagonist, alpha agonist, which works centrally to help control some of the symptoms, but is not a medication we use in the outpatient setting. Graham, would you mind going through just buprenorphine naloxone or buprenorphine alone and methadone and how you think about them?
Sure, yeah. So I think the safest option, certainly for most of us, is Suboxone. And just to be clear, that's buprenorphine naloxone. Hopefully I'm not telling you guys anything new here, but the naloxone is just to prevent people from injecting it. So when people are in the hospital, you can just give buprenorphine. It's the same thing. Do you want to tell me to talk about how to induct it, or?
No, we'll go through that later.
Okay. I think the main sort of divider here, like Sneha was saying, between buprenorphine naloxone and methadone, Suboxone has a ceiling effect. So when you get to the higher doses for people who are on, really heavy doses of opioids, they'll probably get a ceiling effect. And if they're still having withdrawal, that's probably a better patient to put on methadone. Methadone obviously has stricter requirements. It does have higher retention rates and success rates. So it is a good option for a lot of people. But it does require obviously going to a clinic every day, sort of working your way up and getting more privileges, and it's not for everyone. I do want to talk briefly about naltrexone because it is a really good drug, especially for people who have overlying alcohol use disorder, because it does treat both. And the way that we normally give it for opioid use disorder is long-acting injectable Vivitrol. So that's a monthly injection, and it has really good data even when compared to methadone or buprenorphine naloxone. The problem that you get with it is that people already have to go through withdrawal and be on the other side of that to start it, because it will send them into pretty precipitated withdrawal symptoms. So you have to be really careful with using that. If you do decide to start that, a good way to do it is to give them an oral dose of naltrexone and see if they have withdrawal, just because that half-life on the oral is so much less that if you do precipitate withdrawal, it won't last as long.
Cool, thank you. Okay, so then moving on, he is being seen in clinic. You're seen later in the day today, so you don't think you have enough time to start him on buprenorphine naloxone today, so you tell him that you're planning on starting treatment. These are the instructions you give him: to not take any oxycodone the night before visit, so tonight. You want him to have somebody drive him to the visit next day, and he should come in early and should plan on being in your clinic pretty much all day so that we can get him started on buprenorphine naloxone. And this is the plan you come up with him to see him the next day. Unfortunately, the patient no-shows to the clinic, and so let's see what happens with him. So then he is brought into the emergency department after he was found unconscious after he drove his car into a ditch. And so EMS tells you that they gave him some naloxone on the scene. He woke up a little bit. In the ED, these are his vitals. He's somnolent and he has pinpoint pupils. So based on these vitals, what do you think about this statement that you would give naloxone to this patient? Mm-hmm. Okay, yes or no? Oh, we gotta.
Yeah.
Everybody's giving naloxone. Okay, Graham, why are we giving naloxone to this patient?
Yeah, I think the learning point is giving naloxone for respiratory compromise. So if patients come to the hospital and they're high, like you don't need to give them naloxone. They're fine, and they'll really, really hate you if you give naloxone. They'll storm out of the hospital immediately because you'll send them into precipitated withdrawal. So the key is, you're looking for respiratory compromise. This guy's respiratory rate is 8. He's somnolent. You don't know if he can protect his airway. So that's really the indication for it.
Great. Okay, and then he gets admitted to the hospital. And so, Graham, will you explain to us a little bit about how we monitor patients for withdrawal inpatient?
Sure, yeah. So not sort of rocket science here, and hopefully, the lesson is how easy this all is. So there's 2 ways to really do it. This is the clinical opiate withdrawal scale that we use in the hospital. And just going through it, you're looking at their heart rate, tachycardia is indicative of withdrawal. Basically, I think of fluid coming out of every part of their body. So they're sweating, they have diarrhea, they have nausea, they're vomiting, there's tears coming out of their eyes. And the real mark is these people who just sort of can't sit still, who are moving around in bed and really hyperactive is really indicative of withdrawal. The other thing that I'll bring up because we talked briefly about whether we would do this in office, and we know that home induction is just as safe as doing it in the office now. So these patients you can send home with their starter doses. There's a SOWS or SOWS protocol, and it just has all of this, but the patient can fill it out themselves, and it's really pretty equally efficacious and allows them to manage this on their own. So instead of having these objective things like pupil size, it'll say, I feel restless or I feel anxious. And it's equally validated to start on it. So if you're doing a home induction, you can give them that to start out with too.
Great. Okay, so then we're in the inpatient setting. The patient is now admitted with opioid overdose. But fortunately from his motor vehicle collision, he only had minimal injuries. So no fractures. He got admitted on Friday night, and so he tried to call addiction medicine, but they say that they'll see him on Monday. No one on your team has an ex-DEA, meaning nobody has done a MAT waiver and asked for the DEA to give themselves a waiver to be able to prescribe Suboxone. And here's his 5 drug panel. So Graham's gonna go a little bit over what these drug panels are, what we normally get in the hospital, and whether or not the cocaine being positive matters on how we treat his opiate withdrawal.
Awesome. So when we look at the drug panel, hopefully most of you guys know this, opiates that we test for is basically just morphine. So heroin and codeine will metabolize to morphine, but nothing else will metabolize. So if this guy's saying that he's just doing oxycodone and he's showing up with a positive opiate screen, he's probably using heroin or illicit morphine. So that's sort of the first thing. Hopefully you guys know how to order an opiate quant. So this is an immunoassay that comes in the urine. If you're gonna look for the specific metabolites of actual opiate medications and synthetics, you need to order a mass spectrometry. I probably said that wrong. But that'll show you the actual metabolites in the blood and be able to pinpoint some of the synthetics things they're using. As far as coexisting disorders, I think the fact that there's cocaine in his system, you could say the same thing if there was meth or another stimulant. It should not affect the way that you treat the opioid use disorder. So it's sort of like saying, oh, you have asthma, I'm not going to treat your diabetes. It's just ridiculous. It's frankly absurd. So we need to treat them as separate issues. I think the fact that he's using other substances and is at a risky user probably means that he needs a higher level of care transitioning out of the hospital, meaning that maybe this isn't a guy who's getting Suboxone through his PCP, but is at a more comprehensive substance use center where they can monitor him and have really a closer eye on him, knowing that he's higher risk. The one thing that would give me a little bit more pause would be benzos. All the buprenorphine-related deaths, not all of them, but most of them have been buprenorphine co-ingested with benzos causing respiratory depression. But I still think you have to think about the risk reduction. So what's the risk of buprenorphine and benzos versus probably if they're doing heroin and benzos, got to be higher. And we know that, a lot of these overdose deaths are benzo related as well. So that would be sort of how I would think about the UTOX.
Sweet, thank you. The only other point that I would make is when you guys are looking at these UTOXs, sometimes, it's helpful to go and confront the patient of what you found on their UTUCs. You want to be honest about what you are seeing. Sometimes patients will say, well, there's no way, I don't do cocaine, there's no way. But just remember that cocaine false positive rates are like minuscule, and if you see cocaine in their urine, that they've most likely done some cocaine, knowing or unbeknownst to them, in the very recent past. That does not hold true for amphetamines, because remember, medications like Adderall and some other medications can cause the amphetamine to be positive. So in that case, you could give the patient the benefit of the doubt if they're taking other medicines that may cause the amphetamine to be positive. I've only ever seen like one PCP patient here, but if that's positive, they probably did PCP. And then marijuana is usually positive as well, but that can be a long time because it is lipophilic.
And I would not give them the opportunity to lie. So I wouldn't say, why do you think that's there? Did you do cocaine? I would say, I'm sorry, we found cocaine, you've done cocaine. I'm sorry that you don't feel comfortable enough to tell me the truth about it. But I would not leave the door open for manipulation.
Great, thank you. Okay, so in the inpatient setting, he says he's still interested in quitting and he's glad that he's here. So which medication will you choose for him now to treat his use disorder? And he's telling you, so this is like some hours into his admission and he's starting to feel like he's withdrawing. Okay, Steve says oxycodone. Okay. Steve, tell me why.
I mean, it's not because we wouldn't be able to give the Suboxone given that none of us can prescribe it, right, based on I slept out it. The scenario is still the same.
The scenario is still the same. Okay, so Steve says because none of us are XDA waivered that we should use oxycodone. Anybody else? Okay, great. So this is excellent because Graham is about to teach us and drop some knowledge on what we should use.
Yeah. This is the main reason I actually wanted to do this presentation, because this is like drives me freaking insane when I hear that. Sorry, Steve, I don't know. We don't know each other. So that is absolutely wrong. You do not need an X waiver to prescribe inpatient. I'll say it again. You do not need an X waiver to prescribe inpatient. There's a 72-hour rule, which we'll talk about in a sec. I think it is unethical to not give people the correct medication. And if the system around us is built that way, then that's too bad. If you're running into pharmacists and people telling you you can't do it, you need to drop the law on them. And Sneha is going to show that in a sec. So you can do Suboxone inpatient, even if you don't have an X waiver, even if your attending says, oh, I don't know, even if the pharmacist says, oh, I don't know. You just got to really, really tell them you can. Because it drives me freaking insane. I've come across this so many times. I've argued with so many people in the hospital. So yes, that's my rant for the day. The other thing is when people come in for opioid overdose, we have the choice between life-saving medications and non-life-saving medications, okay? There are studies showing that when you initiate methadone, so they did a study of 17,000 opioid overdoses in Massachusetts. And if you start medication-assisted treatment, you have a hazard ratio of 0.47 for more opioid-related mortality. So that's incredible. That's better than any of the drugs that we give anyone in the hospital, right? If you can get this person stabilized, get them through acute withdrawal, you, number one, increase their buy-in in the healthcare system, increase trust in the healthcare system, get them tied in the healthcare system, and you decrease their out-of-hospital mortality in a really big way. So that's my rant.
And then Graham, I picked these choices for a reason. Would you mind just going through each of them and telling us what you think about those answers and when you would potentially use those?
Yeah. So naloxone drip is going to be helpful for the person who's overdosed, who's still somnolent with a respiratory rate in the single digits. Someone who's already starting to withdraw, you're going to make them miserable. Oxycodone and other opiates in the hospital are not a terrible idea, especially if people are, really don't want to quit. I think it's not a terrible idea to give them some long-acting opioid. It's just not the best idea. Clonidine and loperamide are fine, right? They're going to treat symptomatically, but they just don't do nearly the amount that Suboxone does to help people in the hospital. The real answer for this should probably just be buprenorphine alone, because you actually don't need the naloxone component. So when you order this in the hospital, you can just do buprenorphine.
Yeah, great. I just put that because we are likely going to send him out on it. And so I just
Yeah.
used the whole answer. And then sometimes, you hear this last sentiment, which is that opioid withdrawal is not lethal and therefore does not need to be treated. But again, like Graham is saying, we have to practice ethically, and it's unethical to let our patients suffer. And so please do not use that as a punishment for their use disorder. Please treat their withdrawal to the best of your ability, okay? I did put methadone here. Sometimes you can start methadone in the hospital, but you need addiction medicine to help you with that, and the patient needs an outpatient follow-up plan with that. So it's more common that we use buprenorphine. And then, go ahead, Graham.
Oh, I'm sorry, Sneha. I was just going to add, when we don't treat patients for withdrawal, they're going to, instead of the next time they get withdrawal, they're going to go find some heroin instead of coming to the hospital, right? So it's truly risk reduction and getting these people engaged in the healthcare system, which makes a really huge difference moving forward.
Graham, can you remind me, Graham, can you remind me, like you can prescribe in the hospital. The problem is when these patients go to the outpatient setting, if you have nowhere to send them for them to get refills, you're still stuck, right? So as far as I'm aware right now, the VA doesn't have anywhere that you can send patients for Suboxone prescriptions. This actually came up the other day within the VA system itself.
Yeah, I mean, that's a tough question, but there are places around town, the VA does have the addiction clinic. I still think you're doing more harm for these patients by not prescribing. I think, there's plenty of things that people come into the hospital for that we don't have a clear follow-up plan on, but we still treat them with a life-saving medication. So I think if the VA doesn't have that, it falls on us as providers to change that rather than just to keep prescribing clonidine, which is terrible. Sorry.
No, that's great. I will say that when I was attending for my first 2 weeks, none of the hospitalists here have XDEAs, and we had a patient that we needed to send out on Suboxone. It was a holiday weekend, and the clinics weren't going to be open, and so we had to figure out how are we going to send this medicine. So separately from this 72-hour rule in the inpatient setting, there is another rule that says a provider who has a DEA can ask for a one-time exemption to treat a patient in the outpatient setting. You can only give them a prescription that covers them for a day or two until they get into clinic. And so for that patient, because I have a DEA and I'm MAT waivered, I applied for that exemption and now have an XDEA so that whenever a patient needs to get out of the VA on Suboxone, I can at least prescribe that for a little bit of time. And in my outpatient clinic, I can now treat up to 30 patients with Suboxone. So I would encourage you guys to get MAT waivered and get yourselves an XDEA, because especially for those that are going into primary care, Suboxone treatment from a PCP's clinic, I think it will be more and more prevalent. Okay, so we're telling you guys, let me read this chat real quick. I think we're about to answer your question.
So Miranda asked how long after the opioid agonist. Normally their withdrawal symptoms will tell you the answer to that. So when they start to withdraw, it's normally fine. When they're on methadone or long-acting opiates, that's when you run into the risk of inducing withdrawal with buprenorphine. So what I was reading last night said OxyContin or long-acting oxy or the equivalent would be 36 hours, and methadone's gonna be 48 to 72 hours.
Cool. Okay, so we are asking you guys to treat these patients in the inpatient setting. So we're gonna go through how we actually do that step by step. So I can do this for y'all. Graham, feel free to chime in if I say anything incorrectly. And I think you have one teaching point here that I probably got wrong. So first, for buprenorphine plus minus naloxone, so like Graham's been saying, if you're inpatient, you can do just buprenorphine, but in the outpatient setting, we prescribe the combo so that patients don't illicitly inject the buprenorphine, and the naloxone will oppose that. So how do you start this? So you wait until the patient is in withdrawal. So this relates to the question that was just asked. You want the COWS scale to be around 10 to 12. And so they need at least mild withdrawal, but ideally they should be in moderate withdrawal. So you're actually gonna put people into withdrawal. Once the withdrawal has started, you give them 2 to 4 milligrams of buprenorphine. Usually 4 milligrams is really well tolerated, so you can use that dose. You wait 30 to 60 minutes, but I say just wait 60 minutes to let the medication take effect. And if at that point they're still having withdrawal symptoms, you can give another 4 milligrams. And then tomorrow morning, you're gonna start with 8 milligrams instead of the 4 because you already know that the 4 didn't work. And can add sort of doses on top of each other as you need for their withdrawal. And then I hear said that BID or TID regimen is optimal. Graham was teaching me that once a day is also okay. So Graham, if you want to talk a little bit about that.
Yeah, so first of all, like this is, I feel like a lot of the hesitation I come across when I try to do this is like, oh, how do we dose them? It's like you give 4, if they still have withdrawal symptoms, you give 4. It's like super easy. So as far as dosing, when you're going up on the dose, you can do BID or TID. Just to like give an afternoon dose if they're starting to withdraw again. Ideally in the long term, the goal is to sort of reframe these patients' minds. So they're going from this physiological need, like, oh, I need opioids, now I'm gonna take my opioid dose and feel better, to something that's like just a daily medication, and now their life is not focusing on when my next dose is gonna be. So buprenorphine is a 24-hour acting drug for opioid withdrawal and maintenance therapy. So if you can eventually steer people towards just taking a daily dose, most of the people I've worked with think that's a little bit better because you sort of take away this sort of neurobiology of addiction, is you take away them looking forward to getting their, not fixed, but getting to feel better. And you probably just need to go up on their baseline dose. Some patients really like taking BID, and no matter how many times you explain, they just want to take BID. And if it's doing BID and not taking it, obviously it's fine. It's not a bad thing necessarily, but I think daily dosing is generally thought of as better.
Great. In the outpatient setting, usually we think about treating these patients for about 1 to 2 years before you start thinking, well, can I taper them back off of this and get them off all medications altogether? But that is a discussion that you can have with your patient.
Yeah, when we start these patients, normally we say, hey, people with the best success are people who have a stable regimen for at least a year before you even start to think about it. Some patients need to be on it for life, and that's okay. And I sort of liken it to diabetes where, you know, if you're a motivated patient, you can get off your metformin through diet and exercise, but some people just can't, and they're on metformin forever. So I think thinking of it as a chronic disease is really helpful. And then before you start to taper off, really think about where the patients are in a psychosocial perspective, if they're around users and if they're in risky situations before you start to taper.
Fantastic. Okay. And then how do we do this for methadone? So for methadone, this is where you really need to have your addiction medicine colleagues help you, because initiating methadone, while sort of technically easier, again, the patient needs good outpatient follow-up because you can't just give them a couple doses here and then they have nothing outpatient because they're just going to use again. So have your addiction colleagues on board. The starting dose is usually 10 to 20 milligrams. And methadone is better in the case of when you need additional pain medication. So remember earlier I showed you that slide with the comparison of buprenorphine versus methadone. So buprenorphine is a partial agonist, but it binds to the mu receptor with like extreme affinity. And so if you add another opiate on top of it, the opiate can't dislodge buprenorphine and the buprenorphine will stay stuck. So you get no additional pain control. Methadone is a full agonist, but binds with less potency to the receptor. And so when you add, say, like morphine or other opiates to the mix, those opiates can dislodge methadone and you can gain additional pain control. So often in the hospital, when a patient is on methadone, you continue their home methadone dose, but if they have a fracture, you can put them on a PCA, you can put them on additional opiates to treat their additional pain. Remember, like Graham was saying, buprenorphine naloxone has a ceiling effect, and so if the patient has hit the max dose, then you may need to transition to methadone. It does prolong QT, so please be careful, check EKGs, especially when you're rapidly up titrating this medication. You need to check the QTC once or twice to make sure it's not getting very prolonged, and use with caution when you're using other QTC prolonging medications. And then you have to connect these patients to the outpatient methadone clinic. These are federally run clinics, and so really like none of us can get methadone certified. And then they usually start with daily dosing, so the patient has to go to clinic, get their dose, and go about their day, and then go every day. And then once you show that you're doing that and all the other testing, etc., that they look for, then you may gain the privilege to take home doses for up to a week.
Can I add a few things, Sneha?
Yeah, please.
So for methadone, I think it's important to have an idea of what being on a certain amount of methadone means. So if someone's on 80 of methadone, that's about 240 of long-acting oxycodone a day. So when these patients come into the hospital on 80 of methadone and the overnight cross cover gives them 5 of oxy, it's like sprinkling a little fairy dust and blowing it in their general direction. So when they're on like high doses of methadone, you need to treat them with high doses of opioids. We know that like giving opioid users more opioids is risky, but so is not treating their pain when they have true pain. And that often leads, this uncontrolled pain often leads people to seek illicits and not stay engaged in the healthcare system. So if someone's on 80 of methadone a day, I'll start them on 20 to 30 of short-acting oxycodone on top of it. Like Q4 hours, they're not gonna lose their respiratory status. These guys are professional opioid users. So they're gonna be fine. And then I just want to push back on what you said, Sneha, about the buprenorphine. So so in theory, it is a little bit more adherent to opioid receptors. And there's this theory that since it's a partial agonist, you can't get more pain control with full agonists on it. There are certain medications which have a greater affinity. So fentanyl and Dilaudid generally have a little bit more affinity than like oxycodone. So if you're having trouble, you can use those. It's usually best not to take people off their home Suboxone when they come into the hospital because it's hard to reinduce and you have to put them in withdrawal again. So if they're on high doses, you can cut it in half. So if they're on 24 a day, you can give them 12 and then use opioids on top of it. But if they're on 4 or 8 a day, I would just leave it alone and you actually will get opioid efficacy dosing on top of buprenorphine and you don't have to then reinduce them afterwards, which puts them in a good deal of suffering.
Thank you, Graham. Awesome. I like it when you guys push back because I learn just as much as you all do. Okay, and then remember, so for methadone, like Graham was saying, and I was saying, continue the patient on their outpatient methadone dose. If they tell you that they take 40 a day, they know because they've been going to their clinic every day. And so just put them on the dose that they say they take in the outpatient setting. And then you can call the methadone clinic in the morning to confirm that dose and then continue that dose. Remember, like even if you end up giving them more than what they take, methadone doesn't cause a lot of respiratory depression. Plus they're in a monitored setting anyway, so you can just keep an eye on them if you end up giving them more than what they actually take. And then I'm gonna let, so just a quick conclusion to our case. Our patient is now maintained on buprenorphine naloxone and is doing well at his law practice. But I'm gonna let Graham sort of talk us through harm reduction, especially in the outpatient setting with some of our heavier users and people who use more IV drug use. And just remembering that we have ways available to reduce their risk. Graham, can you see what Jordan's saying?
Responding to Jordan's question, so that's something to really coordinate with the anesthesiologists and peri-op providers on. But I think you're absolutely right that you should just continue the Suboxone. A lot of times, though, they will want you on like 12 or less milligrams. So for the people who are using like 24, you might have to sort of start to taper them down before surgery. And if you're their primary doc, it's a good opportunity to reach out to the surgeons and sort of anesthesiologists and see what they're comfortable with. But most of the time, they will need, at least for the heavier Suboxone users, a dose reduction. But completely agree about not taking them completely off of it.
Cool. Okay, so from a public health perspective, Graham, I'll just click through some of these and you can talk about them a few at a time.
You got it. So I think it's important to know, like, some people don't want to stop using IV drugs, and our job is not to say, oh, you're a terrible person, you're not going to stop it, I'm not going to help you. Let's still try to figure out how to get their risk down as an outpatient. So infection screening, most of the time we're pretty good at this, knowing HIV, syphilis. Like I said, using methadone is associated with a 3 to 6 times less probability of becoming HIV positive. So if you're doing the first thing and offering them the right medications, maybe they won't get HIV. Psychiatric comorbidity, obviously, it's really hard to tell, what's coming from the substance use and what's like an underlying psychiatric disorder, but certainly connecting them to the levels of care they need. No hesitation to do Narcan. The important thing is telling patients if you use it, you got to call 911 afterwards. And then if anyone's using meth, you should also prescribe Narcan. Most of the meth in Colorado now, or at least a good portion of it, is cut with fentanyl so that you can do more meth because you're not as like hyped up, I guess. So anyone doing meth should also get Narcan. Clean needles, there's exchanges everywhere. There's laws in Denver that you can't be arrested for carrying paraphernalia, so people shouldn't just ditch their needles and have like dirty needles in garbage cans. The Harm Reduction Action Center is an amazing, amazing organization. They're here like right on 8th and Lincoln. They have all of these things, connect people with treatment. They have fentanyl test strips, so you can test your supplies, see if there's fentanyl in it, and if there is, a lot of these people, sadly enough, will still do it, but you can at least say, why don't you do it around someone? Why don't you have Narcan on hand? And then teaching people safe injection technique, using sterile water, protecting their veins so that when they come in for osteomyelitis, eventually they have it. After long admissions is like a really big time where people can overdose. So if they're doing a gram of heroin a day and then they get cut off completely cold turkey, and they leave the hospital, sort of similar to leaving an incarcerated state, they're at high risk. So make sure you have sort of a warm handoff. And then multidisciplinary care, sort of getting them into places like substance use centers where they can have all that. The other things I added, just sort of thinking about this more, thinking about patients with chronic pain, there's a little bit more data coming out that says buprenorphine is a pretty safe and effective thing to do for chronic pain. So I think we should all sort of keep an eye on that and consider that for some of our patients, especially with coexisting opioid use disorder. Thinking about other centrally acting drugs, not just benzos, but gabapentin, Lyrica, trazodone, like, you know, these are people who are at higher risk. And we see this a lot with people who get into trouble. And then as far as supervised injection sites, which I think would be the dream of a lot of people sort of into risk reduction, that's been discussed in Colorado. Bills have been almost brought forward, but I think it's right now not very politically expedient and is not really approaching ratification. So that's a distant possibility.
Thank you, fabulous. So today we use DSM criteria to identify opioid use disorder and forget ask the questions that like really fit the patient in. Diagnose them, but don't use it against them. We talked a little bit about methadone versus buprenorphine plus minus naloxone in treatment, and then looked at some of the harm reduction techniques. So thank you, Graham, so much. I learned a lot from you. I love doing this co-conference. And then if you guys just have like a minute to answer 4 questions about this conference to see how we can make future conferences better, I would love for you all to fill out this survey. And then just a plug otherwise is remember the election is coming up. For those of you new to Colorado, make sure that you register to vote. Colorado does mostly mail-in ballots, and so even if you're on a 24-hour call, there shouldn't be any excuse for you to vote. So let us know if you need help figuring out how to register. Do you guys have any questions? Yeah, Steve. Thoughts about a transdermal patch? Yeah, so I think